Hello. Thank you very much for coming. I wish all of you good morning. And my name is André G. Machado. I attend a master's program with Professor Sekira in Estacio University. And also residency in Estacio campus in Juiz de Fora, Minas Gerais in Brazil. It's a great honor for me to be here. And well, I came here today to show to you a new surgical technique to remove fracture files from the apical third of curb root canals. It's really interesting technique because it's based on a conservative approach with a minimally invasive philosophy. I like to start thanking to my mentors here, Professor João Batista, and my father and mentor and career in life, Professor André Machado. They're the reason I'm here today. My summary, well, we'll talk briefly about the introduction of fractured instruments, then we'll talk about indications and, well, the technique itself. Indications, the technique, the prognosis we can find, and the conclusions. Okay? Well, fractured instruments, we have to understand that it happens for two different reasons, as Professor Elio explains it brilliantly. First of all, we have a torsional fatigue, which is the file, which is a resistance that the file showed over a intracanal anatomy, and the flexural fatigue when the file is rotating under an angulation. Okay, we have to have in mind that we always need to promote a conservative approach first. Surgery must be our second-hand option. Well, Mandaretti has such an amazing study, amazing paper from 2013, where he explains all the possible managements under the context of fractured instruments, and I do recommend this paper. Well, the conservative trend in endodontics today is something we are passing through right now. I'm not saying that I agree or that I disagree, it doesn't matter now. But I'm just showing here that now we're facing another wave of minimally invasive philosophies. Here I refer three different papers from three different issues in endodontics, and all of them talking about the possible conservative approaches you can find. The indications of this technique I'm about to present today, the technique we named it after window access technique. You'll explain why, you'll understand why. And the indications are basically the same indications for any surgery to remove fractured files. The indications are the same. What will change is basically the counterindication when not to do that. And we have to respect it, and I'll explain it why. The indications then are class 2 plus canals, fracture below the curvature, when you can't reach with an ultrasonic tip, when you can't bypass with hand files, when you can't reach with any system like many in market, as Dr. Andre brilliantly explained here before in his great presentation. Thank you for that, Doctor. It was amazing, all the possible techniques, amazing. When you can't reach with all of these procedures, then we have to think about surgery. And Thompson has such a classic study in 2000, coming up with a number of 55 to 79% of success rate. But we know that it's old now. It's a classic paper, but it's now past 16 years, and technology has developed so much, and we know that these numbers might change. And the latest one I found was Pierre Wogemuth study, 2015, about the gentle wave system, which I believe is such an amazing system, such a huge potential, even to remove fractured files. We have to study more. But this study comes up with a number of 91% of success rate under mesial buccal root, so with less than 30 degrees of angulation. I believe that is a very high number. When we talk about the other 21% Thompson found 16 years ago. Well, that is something to consider. Okay. Well, when not to do the technique I'm about to present here, we have to understand that. It's very simple. When you have to promote absecting your tissue curettage, and we have to respect that. Once you promote this technique and respect these indications, you will have success, and I guarantee you that. I will not go deeper into this issue, when to promote absectomy or tissue curettage, because it is a whole another presentation. But we all know when we need, with independent external type of infections, we have to cut the apex or remove or pull out that tissue, the lesion tissue, okay? So here we have two cases so far that we promoted this technique here. The first case, Professor John tried it for about 40 minutes, and it looks easy actually, because if you see, it was a long piece of file there, but we tried as hard as we could, but we couldn't achieve it. We believe that we couldn't see the file, and well, we believe the curvature of the entrance of the canal was pretty critical, and we couldn't achieve it easily because of that. And the second case, we also couldn't achieve it. In both cases, we had this technique as a project, and we thought about applying that. And here I have two beautiful micro CTs images that represent both cases. The first one to your left, as you can see, the file looks easy to remove. The long axis of the file is parallel to the long axis of the tooth. But actually, if you cross with the long axis of the canal entrance, you find an angulation. And that might be difficult to remove, or it might not. We have to try. We always have to try a conservative way first. The second image here, it is a mandibular molar, but it represents what I was talking about. It was such a high curvature. It was a pretty big radius of curvature, but it was a pretty high curvature also. And the file, if the file breaks over that apical third, it could be really hard to remove. Well, I divided the technique into 5 different steps so we could understand it easier, how it works. Then I'll demonstrate with a clinical report, and I'll show the prognosis we found. Okay. The first step of the technique is based on our pre-operative exams, and I divided it into 2 different stages. The first one with our clinical exam. The clinical exam is based on our diagnosis. And we have to try, as I said many times already, we have to try to remove it from the inside of the canal first. Once we can reach it, we decide surgery. All right, it is a surgery retrieval case. Can we leave the apex? Can we not? If the apex is healthy or healthy enough to keep in there, we will try this technique. So we need CBCT as complementary exam. We cannot do any more surgery, and I believe all you know that by now. We cannot promote any more surgeries without this amazing tool. So we need that for complete surgery planning. Then I simply suggest a Clark's technique for periapical radiographs. So you could have 3 different horizontal angles, 3 different perspectives during the procedure that you could actually see. Here is an example of how precise can the CBCT scanning be. In the green line, as you can see, the length of the tooth, 19.75 millimeters. It is really precise, and again, it is an outstanding tool that we have to use. The second step of the technique, that's when the technique begins to be really interesting. It's the conservative osteotomy. And I always play with my professor. We say, you only cut the bone where the file is. Okay? It's represented by the red mark. As you can see, we only cut the bone where the file is. We will save the apex at this point. But you have, again, to respect the indications, of course. But you can only do that with CBCT. Once you expose the root, you have a methylene blue to check for any cracks or fracture. That is not indicated for this technique. You have to decide if you find those, if you will extract the tooth, or if you will promote a apicectomy. Well, Professor Kim, in 2006, with a classic study about microsurgeries, explained to us how important conservative ostomy is for a better condition of healing, bone healing, and for better post-op pain. You have less post-operative pain. Here we have the third step of the technique. That's the step that makes it really unique. That's the window access step. We promote it with a round burr to promote a first selective wear. Then we use an ultrasonic tip to be really precise and expose the file. So yes, we remove the file from the outside of the root. Okay. Then we remove it with a micro forceps. And it was really easy in both cases we had so far. It was easy to remove. I will show you. The fourth step is the canal instrumentation and irrigation. You have to promote a one-visit therapy at least for the canal that you retrieved the file. And once again, if you respect the limitations of the indications I set here, you're going to be successful. Then you instrumentate the canal, you irrigate it. Then the fifth and last step of the technique is you seal and obturate the canal. You seal also the window access. And I'll explain why the first visit in a little while. I have here a case report to demonstrate the technique to you. Well, that's the first aspect we had for this patient. No pain under the previous undergoing therapy. Another colleague broke the file under the mesial buccal root, and the patient came to us with no periodontal pocket, no sinus tract, and the right upper molar with negative vitality confirmed with the endo eyes. We tried for about 35 to 40 minutes to remove it, and we thought that if we tried more, it would cause a great aggression for the root canal. So we once had this project, so we thought about using it. When we ran the CBCT scanning, that's what we found. We found here apical periodontitis over the buccal root. Another challenge here. Even though at this stage, initial intermediate stage with a type of infection of external dependent infection, but represented by an initial to intermediate phase of apical periodontitis, we have enough literature to base ourselves that a one-visit therapy would be successful still. So we tried. That's what we found here. With a small video. If you change the radiolucency, you can see the file. It's such a great image here. Well, that's our surgery planning, our complete planning with all the measurements we need to promote this technique here. First, you have here in the blue line, you have the point of reference, which I call POR, is the center of the crown, okay, to the beginning of the separated piece. In red, you have the length of the separated piece, and in green, you have the length of the tooth. You need all these measurements in your CBCT planning to start to initialize the surgery and promote a conservative osteotomy as we defend this technique. In another scanning, another section scanning, we have two different lengths that you will need to promote the window access here. In yellow, you find the length of the mesial buccal root thickness, and in green, you find the width of the separated instrument. You need this, again, to guide your window access. And that is all about microsurgery. You have to be as precise as you can. Here's a clinical picture of the osteotomy, and by this time we had already done the burr selective wear, and we were about to use the round ultrasonic tip. That's the windle access done. As you can see, we didn't even have to expose the whole file. We could remove that easily with a microforceps. As you can see there's a gutta percha. We did not obturate the canal. We just placed the gutta percha because it was the first time we did this technique, and we wanted to make sure clinically where the file starts. That was a clinical sign. The reflection of the gutta percha from the inside to the outer root was a type of sign for us to understand where the file was, even though we had all the CPCT planning. We just wanted to make sure. In the red mark, as you can see, that's the windle access. Really conservative. Absolutely conservative. We save so much structure with that, so much periodontal ligament with that, and all the tissue engineering, we can save that. Here's the file removed. And here is the obturated canal and the sealed windle access. You might be wondering how we did that with the open windle access. It's very simple to understand. Our auxiliary was in constant suction over the surgical area, constant suction, and also switching gauzes with hemostatic solution, and also concentrated topic anesthesia. So we could maintain hemostasis, which is really, really important in this case, and we could avoid any type of excess of irrigation solution or debris that will come from the inside of the canal. So it was easily controlled. Here we have our, this picture is just to illustrate when we instrumentated and we prepared the other canals. That's a picture to show after the procedure part. By this time we were placing the temporary composite to check the prognosis, the follow-up. And here's our prognosis. After the procedure radiograph, 1.5 month follow-up and 4.5 month follow-up. As you can see, we can notice the regression of the lesion. It is amazing. It is an amazing aspect for a surgery. This is the second case we have the prognosis so far. The initial X-ray, the after the procedure X-ray, and 4-month follow-up X-ray. It was a more recent one, and this one was, we tried to be even more conservative. It looks really good for surgery. And we have to understand that. We saved so much structure. And as I mentioned before, we have better conditions for healing. Neither of the cases showed any post-op pain. So it is really interesting, really interesting. Once Professor, in a conversation with Professor Sequeira, he told me that no work is valuable if you don't show the limitations. And I agree so much with that. The limitations of this technique, as I have to say, the one-visit therapy, at least for the canal that you retrieve the file, because if you place NTA or a bioceramic over the windle access to seal the surgery, before obturating the canal, you will obliterate the apical third, and you won't be able to promote a right obturation and sealing as we like. So that's why we promote the obturation first, and in the same visit, we seal the surgery. We seal the windle access. But it's really a relative limitation, because if you think about the indications I mentioned here, and when not to do that, if you respect it, you have great chances of success here. The real limitations, in my opinion, are the counterindications of this technique. You cannot do in every case. Absolutely not. When you have an external independent type of infection, you shall not promote this technique because you need to remove the apex and you need to remove the lesion tissue. If it's an independent cyst or any kind of pathology like that, you will have to remove it. So again, this technique is recommended when the apex is healthy enough to be there. And endodontics is about disinfecting and sealing. Once we can achieve that, we will be successful in about anything we do. All the techniques we find, for irrigation, for instrumentation, we are all facing the challenge of disinfecting and sealing, right? So that's what I believe. And this technique respects that, but we have to respect the indications for that. And the achievements we can find of this technique are basically the conservative osteotomy and the significantly, but really significantly less wear. We, as I said previously, we save so much structure, so much tissue engineering of the periodontal ligament. That will help us to promote a better healing, to save that tooth. And of course, all of it avoids post-op pain and better conditions for healing. All right? The conclusions I can find here is that within the limitations of these cases I presented here, we can suggest, but only suggest, a possible positive approach for the previous indications to remove separated instruments once you have a healthy apex. However, more studies must be developed to confirm its real potential, because both cases I showed here only give us the potential of this technique. But we need more studies to guarantee that this technique is such a positive approach that we need, that we can have success with this. And I believe I can do. Professor João came with this project to me about a year ago, and I was so impressed. So I tried to help him as much as I could, doing all the procedures, all the follow-ups. I kept in contact with the patient, and I was really worried about it, really interested. It really called my attention. And as a prognosis and the clinical symptoms we found, clinical signs, all the symptoms the patients showed, it really indicates to me as a good potential. These are my references that I mentioned here in this presentation. If anyone's interested, I can email that. And well, imagination is more important than knowledge. For knowledge is limited to all we now know and understand, while imagination embraces the entire world and all there ever will be to know and understand. Albert Einstein. This is really appropriate for this presentation, because once we connect our scientific evidences with our creativity, with our imagination, we can shape the future. My name is André G. Machado from Estacio University in Brazil. Thank you so much for the care of your attention this morning. Thank you.
Do we have any questions? Please.
Have you ever thought of placing a percha foam in the canal, passively, not condensed, not cemented, and then being able to repair the window with a bioceramic or MCA, and that after setting at a next appointment, you can actually repel clean, shaven, and obscuration?
You're saying that we could place a gutta percha without condensate?
Just to keep the space from being obturated by your sewing material.
Oh, perfect. Well, that is a great point. Well, that is a technique we're developing, and great ideas like yours should be considered. We did not think about that, but yes, if you really need a second visit or more visits, it's such a good idea. I will take it to my professor and we'll discuss it further. Thank you so much for your interest. Thank you.
Any other questions? Okay, thank you so much.
Thank you.
Really interesting.